Good morning. We will be presenting our technique of unlinked double row repair, which is our developed technique. Now we are using this case with the OsteoPeeK 5.5 mm anchor. It's a corticocancellous anchor with good pull-out strength and it is cost effective. The technique is developed by us, which is a unlinked kind of a double row. Now this is a pictorial representation. We do a footprint repair, two medial and two lateral anchors. All the four threads are passed from the medial and two threads are passed from the lateral. So this technique will give us a footprint repair and it is a double row technique, but we don't use any linked and costly knotless anchor in this particular technique. So this is a large U-shaped tear which is laminated. There are two laminas. So what we'll do is we'll do a thorough decompression to just assess the tear edges, and here what we can appreciate are there are two laminas, the inferior lamina and the superior lamina, and it is torn in a big fashion. So it is a long U kind of a tear. There is a large posterior fragment as well. So there is a posterior as well as an anterior flap, and the size of the tear is around 3 to 4 centimeters. The reducibility of the tear is also more anterior to posterior as compared to posterior to anterior. We do a thorough release. We release the superior capsular region just above the glenoid to improve the mobility of the cuff fragment, and we always do a little bit of decompression. The subscapularis tendon was normal in this particular case. So once we do this, once we do a thorough release and once we assess that the mobility is good, we'll pass our anterior and medial anchor first. So this anchor, as we have talked about, is an OsteoPeeK anchor. This is a 5.5 mm peak anchor, and it has got all the advantages of any anchor. It has a very good pull-out strength. It has got a very good purchase. There is no metallic component in it, and there is no eyelet in it. So, and the fixation is corticocancellous. So the fixation is in the cancellous bone as well as on the cortical surface. So this is the first anchor we use, and we will pass all the four suture limbs from this particular anchor. So when we pass our sutures, we take due consideration that we pass the threads through both of the laminas of the rotator cuff. The rotator cuff, as seen in this particular case, I have two lamina, and if you miss the inferior lamina, your repair will always be inferior. So in this is the first thread, and this is passed in the anterior aspect. In this particular case, we are using a self-retrieving anti-grid suture passer. The sutures can be passed in the technique that you wish. Usually, these are strong biofiber number 2 sutures which are loaded on this particular anchor, and as we have discussed earlier, we'll just keep on passing the threads one by one. And since it is a medial anchor, we have to pass all the four suture limbs of this particular anchor. So this is the third limb which we are passing now. And again, we are just using the anti-grid suture passer, which is self-retrieving, to pass the threads one by one. We usually use blue, white configuration, and as we have discussed earlier, we use it in a mattress fashion. This technique has got a lot of advantages as compared to the standard linked double row repair that we are doing. We all know that a linked double row has a very high incidence of CHO type 2 retears because of a heavy compression at the musculotendinous junction, and those retears are very difficult to treat. So in this particular technique, there are less chances of developing a musculotendinous tear, the CHO type 2 tears as they are described, because there is no compression and the biology is preserved. We all know that overall the double row repairs better than the single row, and we all know that there are problems with a linked double row, which includes a type 2 tear because of the compression and decreasing of the vascularity. And these two advantages are in this technique So it is a double row, but this is an unlinked technique. We cover all the footprints. So now this is the posterior suture anchor which we have put in, and we do a little bit of more bursectomy. When we put the posterior anchor and we see the posterior cuff tissue, we see that we need a little bit of more bursectomy. So we'll just do a little bit more of a bursectomy. So in this particular case, we are seeing that we are doing the bursectomy with the shaver itself. Now what we will do is we will pass the 4 threads one by one on the posterior leaf. We will start from the V or the apex of the U deformity or the U tear, and we will pass it one by one. So when it is passed, the first is passed. Usually we pass the first and the second threads through the antegrade suture passage, and usually we recommend. So this is the first suture which is passed through the antegrade suture passage, the blue one. Now the white suture will be taken, and this will also be passed through the antegrade suture passage, and this will be a little more posterior as compared to the first one. And these are deep bites. Again, a word of caution, you must try to include both the lamina, that is, as it is a laminated tear, and we should not miss the 2 laminas. The inferior lamina should not be missed. Now the rest of the 2 suture limbs are repaired by a high posterior medial portal, which is a portal which is located on the back and inferior, and we use a 15-degree up penetrating suture grasper to do this particular step, and we usually pass one limb at a time through the penetrating suture grasper. It is a retrograde kind of a suture passage, and it is a good technique because in this particular technique we can take a deep bite, more deeper than the antegrade suture passage number 1, and we can actually take a position which is more suited to the anatomic repair. So in this particular fashion we have passed all the 4 suture limbs of the posterior as well as the anterior suture limbs. Now we will be passing our lateral suture anchors. Now lateral suture anchors are the similar anchors. We don't use a knotless anchor in this particular technique, but we will pass only 2 suture limbs. So we will repair the lateral suture lateral anchors as a simple knot. So only one limb. So it's a double loaded anchor, but only one limb will be tied. So this is the anterior one, and once this is passed, we will again take a bite again through both of these laminas, but this bite is a less deep bite as compared to the medial anchors. We don't want to take more than a centimeter or so of the tissue. The earlier bite, let's say, is around at 15 millimeters to 2 centimeters. This bite is relatively superficial bite with around about a centimeter cuff tissue. So there are blue tissue and a white blue fiber, biofiber, and a white biofiber, and both of these are passed in a regular fashion, in a simple fashion, and the rest of the 2 limbs will not be passed. You may have some difficulty in incorporating the inferior lamina, but you should always try to include the inferior lamina into your repair. So once this is done, the most of the work is done. The only problem with this technique occasionally you will have a little bit of more entanglement of suture, and suture management becomes. Put the posterior anchor. The posterior anchor is inserted, the lateral posterior anchor is inserted in the same fashion. Again, it will be a simple kind of a knot. So as you see that this is a very cost effective technique, because and this anchor that you see, the thread, the biofiber is right to the tip, and we have a very strong cortico-cancellous purchase in this particular anchor, and there are 2 marks which will tell you that till what level you need to go. Hence, before tying the knots, you have all the 4 anchors into your place, and as we have done earlier, we'll do the passage through a retrograde suture passage using a penetrating suture grasper 15-degree up, and once we do it, you will be able to see all the threads which are distributed in a linear fashion. So the first blue thread is passed, and then we'll use the second, we'll pass it once more using a second suture, and the second white suture will now be passed in this fashion. So once it is passed, the suture passing is done, and the beauty about this retrograde passage is you will have a less crumpling, because those two sutures are in the posterior medial portal, high posterior medial portal, and that will prevent the clumping. Now we will be starting the knot tying. We'll start the knot tying from anterior, and we'll tie the blue one first. So once we tie the blue one will just approximate the rotator cuff into its own position. So once the rotator cuff is approximated from the medial aspect, then we will try the lateral anchors. So this will prevent the classical lifting up of the rotator cuff tissues, which occasionally happens in a suture bridge kind of a technique, in which you don't tie the medial knots. So if you are using a fourth generation techniques in which you do a suture bridge kind of a repair, then there are some considerations, some issues in which the medial part of the cuff is a little bit elevated from the medial anchors and not properly approximated. So this particular, the first anchor on the medial aspect, once you do it nicely, will prevent that particular problem. Once you have tied a one knot into this, then you are fine to tie your lateral anchors, because lateral anchor will reduce the cuff to their own position. Now in this particular technique, as compared to your knotless technique, the positioning of the lateral anchor is important, because the lateral anchor will serve as the lateral most end of your repair. So you have to put your lateral anchor at a place till where you know that your anchor, your cuff tissue can be reduced, because in a knotless linked repair you can put your lateral row anchor anywhere you want. You can put it low also, it will not matter, because the compression is independent of the anchor position. But here in this particular case, the lateral anchor position is important, because the lateral anchor will determine the position of reduction of your rotator cuff. And mind you, the reduction should not be under tension. So your repair should not be under tension. All those repairs who are done under tension will tend to fail over a period of time. So you need not to place your lateral anchor much more lateral. You can just cheat a little bit to put it a little bit more medial than the footprint, and then you can just start tying those knots up. So this is the knot which has been tied, the first knot, and this knot will actually reduce it nicely. Now, as we have discussed earlier, you may have some issues with knot entanglement, and you have to use your suture retrievers to disentangle the knot, which is a normal thing in this particular case. So if there is a knot entanglement, you can use your suture retriever to remove those entanglement. You should not be frustrated by entanglement, because as there are 4 anchors which are all knotted, some of the little bit of entanglement is okay, and till you are able to solve that out, it is not a problem. Now once you do that, you will be able to repair the second anchor, and as I told you, this is the reduction anchor. So this is the first. Here you must always consider to put your knot on the cuff tissue. Always the limb which is passing through the cuff will serve as the post, and you will pull the limb which is passing through the anchor. So always the anchor which is passing through the cuff will serve as the post. So once you have done those, then you can tie the second medial anchor. So this anchor, the second medial anchor can be tied, anterior medial anchor can be tied at this particular position. So once you have done your anterior repair nicely, then you can position your attention to the posterior repair. occasionally it may be difficult for you to find those sutures which you have passed through the penetrator. And a very handy technique to this is to use your knot pusher to guide in the same trajectory to guide your biofibers in. So once you do that, you will be able to catch hold of those knots. Again, we will be tying the knots in a sequential fashion. So the first knot we are tying is from the medial rope, and once we are tying it, we might have to consider removal of the dog ear. So occasionally when you are tying it, you may have dog ear sometimes, and you need to do some special maneuvers to prevent the dog ear formation. So once you are done a good medial tying of the first knot, you can just cut it off. Then you can use the second blue biofiber. Again, in the same fashion, you tie both of them, the anterior one and the retrograde one. The retrograde one is again passed through the same technique. You will be using a knot pusher, and once the knot pusher is in, it is guiding your biofiber in. You can use your suture retriever to take this knot. So again, this particular knot is a knotted anchor on the posterior medial anchor, and this will prevent the lifting up of the rotator cuff tissue. That is a problem with the suture bridge kind of a repair. That is an all knotless repair. So if you do an all knotless repair, the chances of lifting up of the tissue, rotator cuff tissue from the medial anchor does arise, and that may give rise to a poor healing. So in this particular case, we see that there is some dog ear formation, and you can use your knot pusher in this particular way to lift it up and prevent the dog ear formation. So you will have to lift the fiber wire up to just remove the slag and do a repair more posteriorly. So once we have tied both the medial row anchors, then it is a time you can just cut it, and then this is a time for us to repair the anterior. If the anterior one is left, you can just tie the anterior one also. So here we are tying the anterior medial anchor at this particular time. So once we are done with the anterior medial repair and the medial repair, we now are pretty sure about our reduction. The posterior medial anchor is the cornerstone of reduction of the infraspinatus and teres minor. And as we have done for the anterior lateral anchor, this anchor will also reduce the cuff into its own position. So the posterior flap, so these are the fibers of the infraspinatus and the teres minor, and they will be repaired nicely. Again, we'll be keeping the suture limb which is passing through the rotator cuff tissue as the post, and we'll be tying it over the cuff tissue. So once we have done it, once we have passed it, we'll just use our knot pusher to do a proper repair in this particular case. So the first blue anchor is used and it is tied. Now we'll be using the second white anchor, which is again passed from the retrograde technique. So the second anchor is also this is the last suture limb which is passing through the rotator cuff tendons, and this suture will actually reduce all of the posterior cuff tissues into its position, and once it is repaired, it is cut. Now we can use our RF probe to do a little bit more of birsectomy and see if our repair is good or not. Now here we see that there is a slit which is present, and to remove this slit, there is a very nice technique of margin convergence that we do, and we will be closing both of the margins by a special technique. We will be using the first used by the antegrade suture passer, and the second pass will be through the penetrating suture grasper. So the lower part of the penetrating suture, lower fiber will be grasped by the penetrating suture grasper and will be passed like this. So now we have a thread which is just a free limb which is repairing the cuff in a margin convergence fashion, and now we will be tying both of these suture limbs as a margin convergence fashion. So the first limb, the anterior limb, as well as the posterior limb are tied in a margin convergence fashion. So once we tie both of these suture limbs up, there is a very nice approximation of the anterior as well as the posterior flap, and this will avoid both the dog ear formation, and this will be a very good approximation of the tissue over the footprint. So we see that in this particular technique there is no hyper compression which leads to a decreased vascularity. All the techniques we have done are biological. We have done adequate bone holes. The anchors we have used are vented anchors, PEEK anchors, which are bio-inert anchors, and we see here that very nice repair has been. And now we are just doing an adequate decompression, and if needed you can do a little bit of subacromial bony decompression in this at this stage if needed. We don't do it on a regular fashion. Occasionally we see we do a rotatory movements, and occasionally we see that a little bit of the cuff tissue is elevated on the anterior aspect. This is a common finding, and here you don't want to put an anchor. This is a very small gap, and the thing you can do is a crimson duvet here. Again, more of a biology. So you can just use your inserter to put one or two small pilot holes which will develop blood channels and will increase the healing. So we see that we have used all the biological ways to increase the healing. So this particular technique is a more biological repair, a more cost effective way, and which the technique which will give you a more better repair, both as far as the strength is concerned. This is a repair which will be more biological. This will be a repair which is less into tension, because the goals of the rotator cuff repairs are to repairing the rotator cuff into a less tension repair. That is one that can be solved by this particular technique. To increase the biology into the repair, this is solved by this particular technique, and to use a footprint repair or a double row repair, that is solved by the technique. So this particular technique takes into consideration all the good things about the rotator cuff repair, thereby increasing the outcomes. I will like you all to use this particular technique, and if you have any issues or any questions, I'll welcome you all to put the questions into the comment box. As this technique is being developed by us, we will be very happy to answer any questions pertaining to this technique. Thanks a lot.